Hello, ladies and gentlemen. My name is Inowemem Opopo. I'm a second year resident at Florida Atlantic University Internal Medicine Residency Program. Today, it is my pleasure to present an interesting case to you all involving cryptogenic organizing pneumonia in a rheumatoid arthritis patient on Golimumab therapy. Golimumab is a human anti-TNF alpha antibody that's utilized against autoimmune diseases such as rheumatoid arthritis and psoriatic arthritis. There have been studies showing its association with non-infectious pulmonary adverse effects, including interstitial lung diseases. In literature, golimumab has shown these adverse effects when utilized in combination with methotrexate, but not necessarily when used as a monotherapy. I would like to present a case of a 74-year-old female with a known history of severe RA on golimumab therapy that was initiated a few months prior. She presented with progressive cough and dyspnea on exertion, initially hypoxic but improved quickly with nasal cannula. Her chest x-ray showed right diaphragmatic elevation, and a follow-up CT chest revealed bilateral diffuse ground glass opacities with moderate right hemidiaphragm elevation. These ground glass opacities were absent on a prior CT scan that she had a couple months ago. She was initiated on azithromycin for atypical pneumonia coverage, and a follow-up MRI was done to evaluate her cervical spine given her severe RA and the fact that she came in hypoxic. She had spinal degeneration and stenosis involving C3 all the way through C6 with chronic RA changes, for which neurosurgery was consulted but deferred any surgical interventions at the time. Given a hemidiaphragm of unknown etiology, a sniff test was performed and it was positive for hemidiaphragm palsy. Given her persistent dyspnea, bronchoscopy was followed and it revealed findings of interstitial pneumonitis with features of cryptogenic organizing pneumonia. She was therefore initiated on steroids and discharged home on a steroid taper once her oxygen saturation improved for follow-up with pulmonology outpatient for continued workup. Human anti-TNF alpha antibodies have shown to have adverse effects of ILD, and this is well documented in literature. A multi-trial review by the European Medical Association has shown incidences of ILD with golimumab used in combination with methotrexate I mentioned earlier, but no reported cases of golimumab monotherapy use. Our patient, however, shows this. It is postulated that her respiratory symptoms were secondary to her hemidiaphragm palsy in the setting of her underlying ILD, which was just found. It is also possible that she had underlying ILD given the fact that she had been on methotrexate before in the past many months ago, but that was discontinued months prior to initiation of golimumab therapy. Also, she is at higher risk of having ILD given her severe RA as well. The management for such condition, given the degenerative disease of the spine, is typically surgery to relieve the stenosis. However, the patient deferred this given the fact that she wanted conservative measures. In regards to the ILD in itself, which is the COP, the management typically involves steroids, and this is typically weaned over several weeks. And she would require further workup with a high resolution CT scan as an outpatient with pulmonology. The take home point from this case is we recommend a heightened sense of suspicion for ILD in patients with human anti-TNF alpha antibody monotherapy, even if they're not on methotrexate therapy in combination. And they need close follow-up with pulmonology as well, and they will need to be initiated on steroids and followed for resolution of their disease. Thank you so much for your time and attention, and we hope you were able to learn something from this case.